Good evening, everyone. I'm Retnagowri, and I'll be giving this lecture on basic statistics for FRCS. So at the end of this lecture, you should be able to identify the various research investigations, comprehend the basic biostatistical terms, and to be able to apply it to your medical practice. So when it comes to statistics, it can either be descriptive or analytical, and of which then involves either individual population, or a cohort of group, or cohort of patients, or cohort of patient in control. Now, what are the key take home here is that basically in descriptive, you're probably talking more in explaining it in words, numbers, percentages. In analytical, you end up actually using more statistical tests, such as involving the p-value and the confidence interval and so forth. Now, the key thing for you to notice from the slide is that under the experimental interventions, you can actually have a study which is designed to be randomized control trials or non-randomized format. And this can be across clinical trials, field trials, as well as community-based trials. Now, observational studies can either be done or described using descriptive stats, or it can also be done using analytical stats and using p-value. And those are the main things which I would like you all to take home in terms of this slide. Now, taking the next step further in terms of descriptive and analytical, so then clearly more qualitative research will involve more descriptive kind of stats, and in terms of quantitative will involve more analytical kind of stats. The key thing is that across these two things, there are steps which are similar in terms of both involve an inquiry plan, like some sort of survey of performer or something in which we'll collect information. It also starts with a question, a problem, and a question, and then it will end up in directing it to the next problem and next set of investigations which need to be done. They can use charts, pie charts, in different kinds of tables to try and display the information, and also it ends up having some sort of interpretation or making sense of the information which is collected. Now, individually, qualitative research basically is more for hypotheses generating, looking to develop new theories and gather new data. Of course, both ends up collecting new data, but in terms of qualitative, you're kind of having your starting point could be the bare minimum of not really knowing the direction or setting a hypothetical question, but basically generating one. It then hence uses more pictures, text, and charts, and more wordings and paragraphs, and hence, for example, if you end up doing a survey and you're actually asking questions, you might present it in more paragraphs of what was said by each individual. And in terms of sampling, it probably doesn't need much of a sample size, and as well as it ends up being one which it has more open-ended questions, hence more subjective. It's not a yes and no or high and low and so forth. And it actually ends up cultivating in terms of understanding with high validity. While in terms of quantitative research, it then tests the hypothesis or theory. It uses more numbers, as I said, more advanced stats. It needs a decent sample size, enough to actually answer and justify the findings. Hence, it's more close-ended questions which are involved, more numbers are collected, and it has to end up having to be more objective. Hence, what it ends up doing, it will be endorsing, it will to replicate that study. So like RCTs, all of those things will fall under this quantitative kind of research. Now, before we start any kind of going into the types of stats and this, you need to be able to understand the types of variables you're dealing with. So variables can either be categorical, grouped, or it can be matrix, like a measurement, or counted. It can be counted or measured. Okay, so under the categorical, it could be nominal, where it has these things, both of it, categorical has no units, but in nominal, it basically ends up being that it's basically male or female, or a group where you don't actually have a hierarchy, or it doesn't go up. while ordinal actually has levels. So it goes from severe, mild, moderate, severe, and in terms of if it's age, even though it's measured, and if you end up putting into a group, such as 20 to 29, 30 to 39, it ends up being actually an ordinal categorical variable. In terms of matrix variable, it can be discrete or continuous. Basically, continuous, it is basically uncountable. Compared to discrete, it is countable. And examples of this in terms of discrete, where it's countable, is number of deaths, number of Enega attacks. In terms of measurable, where it can go up, your weight can go up as high as possible. Obviously, it's not healthy, but basically, it is considered something which is measured, and it can get to an infinity point, and say similar with height. So now, what are the bases of any statistical test? You end up comparing mean, median, mode. You might also talk in terms of percentages and numbers. I'll get to that shortly. The first thing is to understand the definition of mean, median, and mode. Okay, so here I've put the numbers, there's 11 numbers here, starting from 4 to 10. So mean is basically adding up all of these numbers and averaging it by 11, because there's a total of 11 numbers listed here, and that gives 6.6. While median ends up actually looking at the value which is right in the middle. So what is right in the middle here? So 11 numbers, right in the middle is the number 6. Okay, so you have is it number 6? Yes, it's the number 6, which is the second 6, by the way. So that is basically median. So you line it up in order. I've already put it in order. Normally, sometimes numbers not presented in order like this, but I've just made it simpler. Put it in order for you so it's easy to see. And it's 6. While mode is the most occurring number. What is the most occurring number here? Yes, 5. Right, so that is what a mode is. Why am I telling all of these things? Well, it is important to know that in most cases we do talk in terms of means, but it's also important that sometimes you have to talk in terms of median when the data is skewed. So normally distributed data will end up where your mode, median, and mean will end up being the same or almost the same. So in this case, is this the values which I randomly did in green up there, are they normally distributed? Well, they generally fall within the normal range. So you can still go with the mean or median, up to you. But when it is not normally distributed, you will probably end up opting for something using the median. Why using the median? Because when you are dealing with different variables, there are already some set rules that when it's skewed, it is better to go with median over mean. Because if you're going to go with the mean, it is not going to represent majority of the population which you are trying to represent. So you have a cohort, you want to know what is the most representative value. The mean is not going to represent that. So if you end up comparing it, it will end up giving you wrong, false data. So you will have to then compare the median instead of the mean. Okay, and that is the main message in terms of mean, median, and mode. Just to end this set of slides. So in terms of things which can be presented, as I said, there's numbers and then you will number and its percentage. But when it comes to deviation of the mean, you can either use standard deviation or standard error. And when you're dealing with median, to represent the range, you'll use range or interquartile range. And why is that? It's because you've got all these stats tests which you have to use. This is not, I'm not going to go through every single little box here, but I am going to highlight it in terms of how to compare and contrast it. So you have sample, you've got the population, you collected data, you can do it, you then might deal it in terms of a quantitative analysis or a qualitative analysis. But let's first go in terms of the quantitative analysis. So when you have continuous data, you can either then deal with a pair t-test or independent t-test or ANOVA. What is different? So if you end up having just two groups, you will either do it independently, you will compare using the t-test or paired. What is paired? Paired is if you are saying you're doing an operation and you have a time point before and a time point after, and it's the same patient, so it's paired because it's the same individual. While independent is you have randomized two different, they're going to go for surgery A and surgery B, and you end up randomizing them in. So independent, because you're dealing with different people in each group, and then you'll have to use a t-test, independent t-test. What is ANOVA? When you're dealing with three groups. So maybe your three groups are, then you're giving treatment A, B, and C. That ends up making three groups. So you will then cannot use t-test, you will have to use the ANOVA test. Now and these are all done comparing mean and standard deviation. But what happens if you have to deal it in terms of median and range, or interquartile range? That is, you see the little jetted lines going to Wilcoxon rank and Mann-Whitney. Those are the matching to PAT test, PAT t-test, and PAT independent t-test, as well as to your Christopher-Wallace. You need to know that there is different tests used for different things, and that is what you need to take home here. And it is very important that when you're dealing with these things, the word you use is association. And if you end up finding any significance, you'll say statistically significant, and there was an association between this treatment, or you'll say that there was an improvement and so forth. Don't use the word correlation or risk when it comes to these kind of things. Similarly, when you're dealing with chi-square test, so in qualitative, you have chi-square test or Fisher test. Fisher test is used when the chi-square, when your numbers are smaller, it ends up employing a Fisher test, which ends up giving you some sort of value, and it will give you the p-value as well. And in this case, it's still not correlation of risk. You're still talking in terms of association. When are we talking in terms of correlation? It is when when both variables are continuous. That means you're dealing with a graph where both it is continuous variables comparing, and you're looking at more regression values, which is towards the middle of this flow diagram, like Pearson and Spearson. It's when you're actually dealing with the word correlation between the variables, right? So you will not use the word correlation otherwise. Risk. Now, risk, very simple, is that everyone knows that smoking is an independent risk factor for lung cancer, right? So risk is normally used in the words in terms of when you're dealing with multiple logistic regression, where you're trying to find the factors which are independent from risk factors. Otherwise, risk is hardly used. So don't use risk just because there's association between a certain factor, putting on weight and getting lung cancer. You see that it's statistically significant, it showed some association, doesn't mean it is going to then suddenly say it is an independent risk. It will probably say there is some sort of association, is probably what needs to be said there. Okay, now moving along, let's come to the p-value, which I was mentioning. So I've been telling you p-value. I'm sure a lot of people in the audience know what p-value are, but it is very important for me to highlight that what a p-value is to you all. So basically, it is the odds of getting a certain outcome and it being consistent. So, and hence, a lot of maths was done to say that anything less than 0.05, you can completely reject the null hypothesis, because the chances, it's no more a chance. It is probably statistically not a chance anymore. And that is what the p-value is. Now, what does that mean? It means that you cannot assume the null hypothesis is true. So null hypothesis is the default, right? So hypothesis, you're trying to prove something. Null hypothesis is that you assume that your study is not going to find a difference between group A and B. That's not null hypothesis. But if you're able to show your p-value is less than 0.05, it means you can actually say that there is a difference between treatment A and B. Okay? Now, where it gets a bit more tricky is that you can have p-values. Statistically, things can be significant, but is it clinically significant? Well, that is when a lot of other plays come in, such as effect size, as well as in terms of so to actually really truly drive to say that something which is found is clinically significant, that it is going to make a difference in your practice. So to highlight here are the stars. So you would want something to be statistically but not necessarily clinically significant, then that is not going to be very good. So as long as if it's statistically significant, so that's a green star which I'm showing you here. But what you want to aim more is towards something which is both, that is statistically significant, and you can confidently say that it is clinically significant as well. Okay, so and that is where effect size comes in. Now, how do we look at effect size? So effect size can be either dealt when you want to be most raw, you want to back up your p-value, or it can be used when you're dealing with very small sample size. Sometimes effect size is used rather than the p-value. And there's still debate between a lot of statisticians over using the effect size is more valuable than the p-value. But at the end of the day, we have to go with the maths which we are given, and hence you need to be able to differentiate what is important clinically for you. No point something is statistically significant and the improvement is by 0.1 or the improvement by one, because that might not move you from a group of move you from a severe group down to a moderate group, is it? You want it to move like significantly, that you're actually showing improvement, that whoever is severe now is now moderate, and whoever's moderate is now mild. That's when it's clinically relevant to you all. So P's that it may be all significant on paper, we want it clinically significant. Now effect size, basically anything which is 0.8 and more is considered a large effect size, which means it's good. Okay, and obviously the bigger the effect, the numbers can keep going up, there's an infinity to it, where it can go from 1.5 to 2 and so forth, but as long as it's 0.8, you can say it's got a large effect size. And normally in studies where they're dealing with small numbers, they will try to prove, at least get enough numbers to have the median effect. Okay, so that there is going to be a clinical change and not just a statistical change. So just like having human errors, stats can have errors too. So in this case, coming in terms of rejecting the null hypothesis, you want to be able to find the true positive outcome. So you want that the test is positive and the truth is also the same. It has to match. So in type 1 and type 2 error is when you say something is, so in type 1 error, basically it's a false positive when actually it's a negative result. The truth is actually it's a negative result, but you're saying it's positive. While in terms of the type 2 error is when the results is actually positive, you end up saying it is negative. So you are not predicting what you're supposed to predict. And hence the example of the pregnancy image here, where in terms of false negative is when someone is actually pregnant, you're actually telling them you're not pregnant, when it's obvious they are pregnant in the image. And this is why it is where sample size calculations and power comes crucial, where they need sufficient sample size so that your p-value has value to it. Okay, so but the sad thing is because you cannot reduce one error, and the reason being is because you cannot reduce one error without increasing the other. Hence, sample size tries and actually aid in balancing out these type of errors which can happen. Okay, so now comes to studies which are superior, inferior, and non-inferior. What does it mean? It means exactly what it means. Superior, showing that treatment A, your new therapy, is much better than your old therapy, while inferior is basically showing your new therapy is nowhere better than the standard therapy, so you stick with the standard therapy. Okay, and the other is at least showing, so maybe you want to release more than one kind of therapy out there, and you want to at least show that doing this new intervention is equally as good as the current standard practice, and that is non-inferior. Basically, you're proving that even though you come up with something new, it is equally as good, so people have options on what they want to use. And that's basically the terms which you need to understand when it comes to the study designs. Well, or study analysis in this case. Okay, so why is this important? Because sometimes you're not always trying to prove something to be superior. Sometimes you're trying to prove something is equally as good. So you really need to understand that not everything needs to be, the p-value does not always have to be more than less than 0.05. Sometimes you do want to show that it is more than 0.05, and that's when you read papers, you need to understand these things. So now let's look at univariate and multivariate analysis. Okay, so first of all, the variables which you see here are looking at whether these sex, age, education, and insurance base, whether people have access to this or not, is basically what's looking at. And a univariate is looking at it at each factor individually and its significance, while a multivariate pulls all of these variables together and then sees whether, even by putting it all together, whether something is dependent on each other or not. So univariate just tells you that yes or no. Multivariate tells you whether it's an independent factor or a dependent factor. Now coming to odds ratio. The odds ratio is basically the ratio telling what are the odds of people being female or male getting access or not. So it's the odds higher, so the higher the value, so it ends up being 2.2. There is 2.2 more odds of you being a specific age group not getting access. It's basically what you're going to end up saying. 95 confidence interval is basically the range to it. So like, with mean, it's so-called plus and minus a standard deviation. For median, it's range or interquartile range. So in this case, for the odds ratio in these kind of things, the plus and minus is the 95 confidence interval. How confident it falls that these odds are correct and that it's not going out, and that the whatever p-value you see is significant, statistically significantly supporting this, is basically what you need to know with this. Okay, so now we're coming to meta-analysis and looking at forest plots and funnel plots. Normally this is done after a systematic search of literature. As you can see here, there are about 6 papers which end up having similar, looking at the comparison of the treatment versus its control treatments, probably a randomized control trial or non-randomized, but given these control group, given the treatment and not. And they've pulled data together and they have found, and looking at basically, in this case, the outcome they're looking at is death, right? So being on it, whether compared to the control survival is better or not, it reduces the death or not. It's basically what this study is looking at. What you need to highlight, so just as previously mentioned, odds ratio looks at what are the odds of you being on it reduces the deaths, as well as not compared to not being on it. The next it looks at is the 95 confidence interval. How confident are you about these results? And then the p-value is then you will have general p-value is then pulled together as one p-value. In this case, it's found that it is statistically significant. The p-value is 0.03, so it is statistically significant. So what does that mean in terms of interpreting the I2 results? So I2, now you want your studies to be have some heterogeneity, that it is not so different. So you would want it to have so anything which is more than 50% heterogeneity, that means it's more than 50, and when it's 0, it means they're quite homogeneous, right? But the main thing here is that you want to prove that none of this is by chance. Is why the I2 value is looked at. Then the funnel plot is also equally matched along with this forest plot in most cases, because you want to, this image here is not the matching to this particular study. It is an image on its own, which I am showing. But here you want to make sure that the papers which are there are, the level of biasness is less, and that is what you want to aim for. Low is the bias is low. So, and those are the blue things. And the funnel plot is like a normal distribution. Say if you take a normal distribution curve, this is a normal distribution triangle. You want it to be towards the middle, inside the triangle as much as possible, and close to that line in the middle and towards the top. The higher the study, the less biased it is. The lower to the bottom of that triangle, the less it's more the bias the study is. So in this case, I would say that if you're going with this, you will probably then conclude that more work needs to be done, or more RCTs need to be done before a meta-analysis forest plot can be done. Or you can still publish it, but then you'll say more work needs to be done to be really truly to say that that particular treatment is beneficial in reducing death or not. And that's basically the concept and the interpretation of in terms of meta-analysis plots in general. Now coming to ROC curve. Basically an ROC curve is done to be able to predict true positive results, which we want to see, that you're actually picking up the disease and nothing else. And hence you want it to be as sensitive and specific as possible. And that's when the area under the curve comes in as a very important thing, because the Anything where the area is higher to the top, where specificity and sensitivity matches as much as possible, it just comes to 1, then it's a very excellent test. So that in terms of COVID, you want to not tell someone has COVID when they actually don't have it. You want to actually, and someone, you don't want to miss out someone having COVID, right? So you want the test kits to be as good as possible. Okay, so in this case, very good. So hence, anything more than 0.8 normally is already considered a very good test. Now coming to, but that's not just enough. You say it's a good test, but you don't want to have, say we talk in terms of biopsy. You don't want to miss a biopsy, right? So this is where the positive and negative predictive values calculations come in, because you want to have a very good positive, and your positive and negative predictive value percentages should be very good. In order for that to be good, you need to, so in this case, you don't want to miss more than one case, or you don't want to accidentally say someone has lung cancer when they don't. You don't want to biopsy and say, yeah, lung cancer when they actually don't have it. So the I wouldn't say balancing, but the more towards getting a very good predictor and pickup rate has to be good is the whole concept behind this ROC curve and area under curve and predictive values are. So now coming to another graph which you will come across, which is the overall survival curve. There are different kinds of survival graphs. We are just going to focus on overall survival here, okay, where you will, the main thing is when everyone is surviving, the line should go across. So if no one is passing away, there shouldn't be a drop in any of these lines. But the minute someone passes away, the line drops. And if more than one person passes away, the line drops in a bigger drop. So if it goes down, someone's down. If it goes across, people are surviving. Okay. Now in this case, to find the p-value or the significant, whether there is significance between these things, will end up being a log-rank test is used. That is the matching test to a Kaplan-Meier curve, and you can use, this is done using statistical tools such as SPSS and so forth. But what you need to know here is that here it's comparing the patient groups with small cell lung cancer and people with IPF or with IIP, or a group where they have it but without these two. And what they have found, and they ended up using median days in terms of looking at survival rather than using mean, probably generally because these kind of generally you end up using median in these cases in general. You can use mean if the data ends up being normally distributed. So median is used here, and confidence interval to show that these days are important. What you're seeing is within the range. Confidence interval is used instead of range when it comes to a Kaplan-Meier curve. Now, what is the take-home message, or what is the difference seen here? So it's very important when a line crosses. So you see the green and red line have crossed, which means those two things are probably not statistically different from each other. But the blue line is the ending of the blue line does not cross at any point with the other two lines, which means they are significantly apart. So what does that mean? It means hence the p-value which you're seeing is trying to show basically the blue line is statistically significantly in terms of has a better survival than the ones which are in red and green. So and that is basically what this result is trying to show. And this is how you interpret survival, overall survival curves. Okay, so to summarize, p-values is important in terms of statistical use, but it's not the standard goal when it comes to the types of samples you're dealing with. Hence, effect size comes into play, because we want to be able to confidently say what you are finding statistically is also clinically relevant. And it all comes down to you predicting an outcome, whether someone has a disease or not, and be able to truly give direction for your clinical practice. Thank you so much for listening to my talk. Have a good rest of the evening. Enjoy your rest of the weekend, and take care.